members who are attending today's CME. Today we have only one speaker and one topic to be discussed. ECG at a glance by Dr. R. Ramesh, Chief Medical Officer, Heart City, Kaveri Hospital, Trichy. I'm handing over the session to Dr. Malathi.
Hello everyone, good afternoon to everyone. So it's great pleasure and nice to see you all today afternoon, today's CME program. So we have today most important topic ECG and good speaker Dr. Ramesh. So our daily practice, day-to-day practice, everyone, each of us have some ECG patients. We advise ECG for all patients, many patients. So most of the time, some abnormalities comes, we don't know how to interpret the ECG. So we have to call some cardiologist or physician for their help. So it's better to understand the ECG basics. So today we have Dr. Ramesh sir from Kaveri Hospital, Kaveri Heart City from Trichy. He's the chief medical officer in Kaveri Hospital. So sir is a cardiologist and he writes about ECG in various journals, including our IMA journal. Last month it's released. So thanks sir, thanks for accepting our invitation. So I welcome you sir for today's CME program. Hope everyone have the ECG interpretation will be clarified. We are going to learn more important points today's CME. Members have can chat box can raise their questions in the chat box. And at the end of the session, we have the interactive question and answer session. So I hand over the session to Dr. Ramesh sir. Sir, you can share your screen and I welcome you, sir.
Thank you so much, madam. Let me first share my screen. I must really thank your President, Dr. Veena, and your Secretary, Dr. Malathi, for giving me this wonderful opportunity. And also, I must profusely thank all the members of IMA. Before I open, let me confess that I'm not a cardiologist, as Dr. said. I'm actually a laparoscopic surgeon, interested in cardiology, doing a lot of cardiology here. So, with this in background, let me open my session. Before I start my lecture on the ECG, I must pay my tributes and salutations to my guru, Dr. Chennai. I think somebody's mic is open and it is keeping disturbing. Okay, let me pay my salutations to my guru, Dr. Chennaiappan, from whom only I had learned all the ECG, and whatever I am today is because of him only. My salutations and my tributes to my guru, Dr. Chennaiappan sir. I am sure most of you, every one of you should be knowing him. You would have heard him also in some forum. And no lecture on ECG can start without paying tributes to this great gentleman, the father of our ECG, that is the Dr. William Einthoven. He is the one who discovered ECG as early as 1902. It is 120 years old now, and whatever he described 120 years old back still holds good, and the concepts remain the same. Only the technologies have changed. The ECG machines look, the technology has changed, but what he described as the PQRST is the same even after 120 years. It is only one test which has stood the test of time. And for this great discovery, he was awarded a Nobel Prize in the year 1924. This, let me move on. So today, Dr. Malathi requested me to give a talk on ECG. I accepted it because the basic concept that every doctor, whatever be your specialty, be a physician or an obstetrician or a dermatologist or a gynecologist, whatever be your physician, as Madam rightly said in the introduction talk, we should have some basic ECG knowledge. Without that, we'll be looking blank. That's what I was like that when we started my practice. I was looking blank at the ECG till I learned from Dr. Chennaiappan sir. So we should have a basic knowledge of the ECG, and for that, we must, at least, if not, we need not become masters, we need not be pundits in that, but only thing is we must have a basic, we must at least be in a position to identify an abnormal ECG. You must be able to say that this is not a normal ECG and refer the patient to the right person so that you will take the timely action. So the concept or the purpose of the talk today is to identify an abnormal ECG. And how do we identify an abnormal ECG? If only we know the normality, we can identify the abnormality. So that is going to be the essence of my talk today. I am going to tell you what are the normal values for the each wave in the ECG. And by that, when you find an abnormality, you will not only at the end of this talk call it as an abnormal ECG, you must be in a position to identify a possible pathology in that ECG. And at the same time, you must be in a position to rule out a pathology also. For example, you should be in a position to confidently say there is no conduction block, there is no bundle branch block, there is no AV block, there is no coronary artery disease. So you must be able to identify a possible pathology as well as rule out a pathology at a glance. At the end of this lecture, this 1 hour, I challenge every one of you in a position to identify. You need not go into the depth. ECG is a vast subject ocean. You can keep learning for years together. So today's purpose and the scope of the talk is to make you be sensitive about an abnormal ECG and identify a possible pathology. And above all, I would like every one of you, I would like to trigger an interest in every one of you to learn more in ECG. Because generally we don't show a big interest in learning ECG. If my talk can trigger an interest in you that you should learn more and more in the ECG, that will be a great service for the humanity. You will learn, identify a lot of pathologies and serve the community. So with that background and the concept of my scope of my talk, let me proceed further. And before we understand what I am going to talk to you, we should understand something about the basic conduction system of the heart. Conduction system of the heart is nothing but the path in which the electrical impulse travels in the heart. You know, the heart has its own capacity, inherent capacity to generate its own electrical impulses from a specialized structure in the heart called the sinus node or sinoatrial node, SA node, which is situated in the right atrium at the junction of the superior vena cava and the right atrium. There is a specialized structure which is capable of generating an electrical impulse at the rate of about 60 to 100 per minute spontaneously on its own. So this impulse, which is generated in the SA node, is travels
Yes, sir.
through the atrium to the next landmark in the conduction system called the AV node, atrioventricular node. And when it travels through the atrium through three internodal pathways, right? Three internodal pathways. So the impulse is originating here, traveling through the atrium and reaching the AV node. So as the impulse travels through the atrium, that depolarizes the atrium. That means it stimulates, creates an action in the atrium. It makes the atrium contract. So that is called the depolarization of the atrium. So after depolarizing the atrium, it reaches the AV node. The AV node behaves like a speed breaker. It doesn't allow the impulse to just like that go to the ventricle. That stops that impulse, analyzes that impulse, whether it is a good impulse, quality impulse, which is worth being conducted to the ventricle. So after satisfying that it is a good impulse to be conducted, then it allows the transmission of that impulse to the ventricles down below. So when the impulse gets out of the AV node, that travels through a thick bundle called the bundle of His or His bundle, which again divides into two branches, a right branch or right bundle branch, which supplies the right ventricle, and a left bundle branch, which supplies the left ventricle. This left bundle branch, as soon as it comes out, divides again into two branches, an anterior fascicle and a posterior fascicle. These fascicles ultimately arborizes into small branches called the Purkinje fibers. So this system is like your electrical wires in our house. The electricity is generated and reaches the point. From there, the electricity is conducted through some copper wires. Similarly, there is a wiring system in the heart, which we call it as a conduction system. We call it as a specialized conduction system because the impulse, if only the impulse travels through this pathway, your ECG is going to be normal. If the impulse for some reason is traveling through the muscle and not through this specialized conduction system, your ECG will become abnormal. We will see that subsequently. So this is the conduction system. So when the impulse travels along, at the same time, it depolarizes the ventricle. So from the sinus node, when the impulse travels through the atrium, the atrial depolarization happens. The AV node stops it, analyzes, and sends it to the ventricle. And when the impulse travels through the ventricle, it depolarizes the ventricle. And the impulse leaves the ventricle, that is called the ventricular repolarization. Our ECG records only this. Our ECG records whether the depolarization and repolarization, whether the atrial depolarization and depolarization, ventricular depolarization and repolarization are happening normally, whether that impulse is traveling in the right direction along this conduction path, specialized conduction pathway, whether it is traveling in the right direction, whether it is traveling in the right speed, and whether it is reaching the ultimate end. So this information alone is given by the ECG, and it does not give us any mechanical information like how the mitral valve opens, what is the orifice of area of the mitral valve, or how the aortic valve opens, whether it is a bicuspid or tricuspid. Such type of mechanical information is not given by the ECG. ECG gives us only the electrical property of the heart, right? So this is what is happening. From the SA node, the impulse is fired, reaches the AV node, and during its passage to the atrium, it depolarizes the atrial muscle, which is produced as a P wave. Then subsequently, it gets delayed at the AV node. Then when it reaches the ventricle, that produces a ventricular depolarization, and impulse leaves the cell, that is ventricular repolarization, which is represented in the ECG as the QRST. So when this impulse reaching the ventricle or the atrium, that electrical stimulus is converted into mechanical energy so that the heart contracts and relaxes. Depolarization contracts, repolarization relaxes. So that is what it is continuously doing. So this is the genesis of the ECG and then how it produces. So this is called the specialized conduction system. The impulse is supposed to travel along this only, right? So to coming to our topic, how we are going to understand one single ECG complex. This is one ECG complex. This ECG complex has 4 waves, 3 segments, and 2 intervals. So wave means an up or down deflection is a wave. Segment is a flat line between 2 waves is a segment, and interval is the time between 2 waves also. So what are the 4 waves we have? We have the first positive deflection of the ECG is the P wave, which represents SA node activity, atrial depolarization. This means the SA node has fired the impulse here. It has traveled through the atrium and has produced the atrial depolarization, which is represented in the ECG as P wave. Then subsequently, the P wave gets halted in the AV node. So that delay that happens in the AV node is represented in the ECG as the PR segment. Between the P wave and the R wave is the PR segment. Then subsequently, the ventricle reaches the impulse reaches the ventricle, which produces ventricular depolarization, which is represented in the ECG as QRS complex. QRS complex represents ventricular depolarization. Then the impulse leaves the cell, which produces another wave called the T wave. Ventricular repolarization is the T wave, and final Purkinje fiber repolarization is represented in the ECG as U wave. So these are the waves of the ECG. So in other words, this P wave represents atrial depolarization. Atrial means it is biatrial. Both the atria together is atrial depolarization. So when you see the P wave from tomorrow, you have to don't see it as a P wave. What you have to identify is SA node as spider impulse, the atrium is depolarized. PR interval represents the delay that is happening in the AV node, which is called the AV nodal delay. QRS represents the ventricular depolarization, T wave represents the ventricular repolarization, and U wave represents Purkinje repolarization. I'm sure all of you know this. The entire lecture is going to be a sort of a revision for you. All of us may know this, just a sort of a revision for you. So with this basic concept in mind, so this is the basic issue. So what you have to understand is the sinus node has fired an impulse. It has reached the atrium. Atrial depolarization has happened. It has reached the AV node. The AV node is giving the expected delay. Then it has reached the ventricle. The ventricle is getting depolarized. Then the ventricle cell, the impulse leaves the ventricle, which is called the ventricular repolarization. This is how you have to mentally imagine the progression of the PQRST, the ECG wave, right? Now let us try to see what are the normal values for each wave. Let us first take the P wave. You all know that P wave represents atrial depolarization, and that is the biatrial depolarization. Somebody's mic, if you can switch on, I think making on. It is making a lot of noise. So P wave represents atrial depolarization. And how do you measure the P wave? Best lead would be the lead 2. Suppose lead 2 is the best lead where you will see the P wave nicely. P wave is a very small wave. Our eyes will have to strain to identify a P wave. It will be too small, tiny. So which is the best lead which will show the P wave nicely is the lead 2. So when you want to analyze the P wave, go to lead 2 and look at the P wave in lead 2. That's where the P wave will be nicely seen. So how do you measure the P wave? How do you measure from the beginning of the P wave to the end of the P wave? This is the measurement. So this is a measurement. So this is a wave, isn't it? It is a wave. So wave means it has two dimensions. One is the height in millimeters. Another is the width in duration or in seconds. So height represents the amplitude. The width represents the duration. That is how long it takes for the depolarization to complete is what is meant by the duration. So P wave has two components, height and the width. We should know what is the normal height, what is the normal width. Normally, the height, or in other words, the amplitude should be 2.5 millimeters or 2.5 small square. Vertically, one small square is 1 millimeter. One small square is 1 millimeter. If it is five small squares, it is 5 millimeters, like that. So vertically, the height of the P wave, normal P wave, should be less than 2.5 millimeters, and horizontally, that is the duration. Vertically measures amplitude, horizontally measures the duration. So horizontally, again, once again, easy to remember, same 2.5 small squares. So it will be very difficult to measure 0.5 small square itself is small one. In that, to make it half will be very difficult. So for practical purposes, 2 to 3 small squares, 2 to 3 small squares in the height as well as the width. Both ways, it should be the normal. So a normal P wave, the maximum height of the P wave should be 2 to 3, and maximum width of the P wave should be maximum 2 to 3 small squares in the ECG paper. Right? That is the normal values. So this is how you measure from the beginning of the P wave to the end of the P wave. So how many small squares it occupies? 1, 2. That's all. What are the height it occupies? 1, 2. That's all. Maximum it can go up to 3 or 2.5, not more than that. So this is a normal P wave. So suppose what are the possible abnormalities in the P wave? We know what is a normal P wave. So what are the possible abnormalities in the P wave? The abnormality can come either in the height or in the width, isn't it? Either in the height or in the width. It can be a very tall P wave or it can become a wide P wave. So let us understand what is tall P wave, what is wide P wave, what is the clinical implication. So whenever you see an abnormal P wave, either tall or wide, that means there is a suggestion of atrial enlargement. You know, P wave represents the atrial activity, atrium, left atrium and right atrial activity. So when the P wave is abnormal, then definitely there is an abnormality in the atrial size. So you must suspect atrial enlargement. Tall P wave, suspect atrial enlargement. Wide P wave, suspect atrial enlargement. Again, still we can narrow down. See, for example, if it is a tall P wave, that is tall means more than 3 small squares. If it is a tall P wave, you must suspect a right atrial enlargement. If it is a wide P wave, the abnormality is in the width, not in the height. If it is a width, then the abnormality in the width means you should suspect a left atrial enlargement. So these are the two abnormalities that are possible in the P wave, tall or wide. I will give you ECG examples. I'm sure you can easily identify this. So you can also answer unmuting yourself also, so that it can be a very interactive session. You can parallelly keep talking to me also anytime. Right? So let us say I'm giving you an example of an ECG where we are now concentrating on the P wave. Let us now concentrate on the P wave. We're talking about the P wave. Let us say I told you the best lead to analyze the P wave will be lead 2. So go to lead 2 straight when we want to look at the atrial problem. Look at the lead 2. This is the P wave. P wave, QRS, T wave. Look at this P wave. Do you think this P wave is a normal P wave or an abnormal P wave? Can somebody keep interacting? We can keep interacting, please. No issue. Do you think it is a normal P wave or abnormal P wave? I told you what is normal P wave. It should be not less than 3 small squares and not more than 3 small squares in width. It looks small, isn't it? It is not very tall. It is a normal 2 small squares only it occupies, and horizontally also it occupies only 2 small squares. So it is a normal P wave only. This is how a normal P wave should look like. See here, a normal P wave to lead to. See how much, if we can count the number of small squares, it is just 2. Again, width also it is just 2. From here to here it is 5. From here, the one big square contains 5 small squares. So this is just 2 small squares. So it is well within the normal limits. So it is a normal P wave. By that, what we understand, it is unlikely that the patient has any atrial enlargement. Unlikely that patient has any atrial enlargement. That is what we understand at this point of time. Okay, I will show you another ECG. Again, concentrate at lead 2. See this P wave. Do you think this is, compare with the normal P wave here, do you think this is a normal P wave or an abnormal P wave here? Can somebody just interact?
P waves are tall here, sir.
It is an abnormal P wave. I'm sorry, I couldn't hear what you said. Okay, it is definitely an abnormal P wave. What is the abnormality? The abnormality lies in the height. It is almost equal to the height of the QRS here. So it is about 4 small squares here. So it is an abnormally tall P wave. So what do you understand when it is a tall P wave? Tall P wave means, I told you, it is suspect right atrial enlargement. So when you see a tall P wave like this, suspect right atrial enlargement. See like this, tall P wave. This is the P wave, this is the QRS. P wave and the QRS are almost of the same height. So it is a tall P wave. See how many small squares it occupies? 1, 2, 3, 4, almost 4.5 small squares. So it is definitely a tall P wave. Immediately you can definitely say there is a suggestion of right atrial enlargement. I'll show you another example of P wave. Again, lead 2, concentrate on lead 2. See this P wave. What do you think is the abnormality? Is it normal or abnormal? Obviously, it is abnormal. It is obviously abnormal. What is the abnormality? There is no problem with the height. Height is normal. It is only two small squares. But the problem is with the width. See, such a wide P wave, about 4 to 5 small squares width. So it is a wide P wave. So whenever you see a wide P wave like this, suspect left atrial abnormality, right? So it is a left atrial abnormality. So you know how to diagnose a right atrial enlargement by a tall P wave, left atrial enlargement by a wide P wave. So these two diagnoses you can definitely make. You can identify it as a abnormal P wave. You also know what is the abnormality due to, right? See, such a wide P wave. Suppose sometimes there may not be a P wave at all. Suppose there is a ECG. You look at the ECG. Say, I'll show you the ECG. See this ECG. You don't see a P wave at all. You see only QRS, 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 QRST, QRST. You don't see a P wave at all. So there is the third abnormality which you can get about the P wave. When you don't see a P wave at all, what you have to infer is the sinus node has not fired an impulse and it has not generated any atrial depolarization. Then how is the patient alive today? Is because of when the primary pacemaker, that is the sinoatrial node, fails, then you have ready reckoners like our UPS or our inverters in our house, where the alternate secondary pacemakers, which will take over and give a electrical impulse. So that is called the escape beat. We will not understand it now, but just understand here that when you don't see a P wave, please understand there is a problem with the SA node. It has not fired an impulse. It does not produce a atrial depolarization. So that is the implication of no P wave. So if there is no P wave, it is a suggestion of a sinus node has not fired an impulse. So the primary pacemaker has failed. Some of the secondary pacemakers have taken over. Could be a sort of a sinus arrest or a sick sinus syndrome. We will not try to understand all these things now. So this is the diagnosis. So three abnormalities: tall P wave, right atrial; wide P wave, left atrial enlargement; no P wave, no sinus node activity. So three abnormalities as far as the P wave is concerned. We will now move on to the next wave, that is the P or interval. If you have any doubt, please note down and we can discuss at the end. Or if you want to interfere right now, we can also talk in between. So next we will move on to the P or interval. I told you P or interval is the distance between the P wave and the R wave is called the P or interval. It represents the AV nodal delay. You know, I told you AV, the impulse reaches the AV node. There it gets halted. The AV node behaves like a speed breaker and stops the impulse and analyzes. So this AV nodal delay is God-given gift to a human person. Why? Because the AV node is the one which protects the ventricle from rapid supraventricular impulses. Supraventricular means above the ventricle, that is the atrium. For example, we know certain clinical situations where there is atrial fibrillation, atrial flutter. What is happening in atrial fibrillation? Atrium is fibrillating, not contracting. When it is fibrillating at about, say, 200, 300 beats per minute, then if all the 300 atrial impulses are going to be contact to the ventricle, what will happen? The ventricle also will fibrillate. What is ventricular fibrillation? It is equal to death. So the AV node protects the ventricle from allowing these fibrillary waves from the atrium to the ventricle, that stops and analyzes and sends only the good impulse to the ventricle. So that is the main purpose of the AV node, the delay in the AV node. That is the main purpose. Second is, naturally, when the atrium is contracting, the ventricle has to relax and receive the blood. If atrium and ventricle are contracting simultaneously, then that the movement of blood cannot happen. From the atrium, it has to come to the ventricle. So when the atrium is pumping, the ventricle should receive it. So there should be a delay between the atrial contraction and the ventricular contraction. So that delay is given by the AV nodal delay. And third is, booster kick effect is 30% of the cardiac output is contributed by the final atrial contraction. You just ignore it at this point of time. These are the main two purposes of AV nodal delay, and this AV nodal delay is represented in the ECG as P or interval. So again, once again, the best lead will be lead 2 because lead 2 is the lead where you see the P wave nicely. If only you see the P wave nicely, you can measure the P or interval correctly. So this is the lead 2 is the best lead to analyze the P or interval. So how do you measure from the beginning of the P wave? Here, the beginning of the P wave to the beginning of the QRS wave. This is the P or interval. Or sometimes for convenience sake, some people will measure from the peak of R wave to the peak of QRS also. Both are correct. You can measure either way. Both will be almost the same. So it is a flat line, isn't it? It's a flat line. So there is no, it is PR segment, this is the PR interval is a flat line. So there is no wave, there is no height. So no problem with the height, there is nothing like that. It is only the duration or the width. So what is the maximum duration or maximum width a normal PR interval can have? In other words, what is the maximum delay that the AV node can offer? That is what is the PR interval. And the value is 3 to 5 small squares. So your PR interval from the beginning of the P to the beginning of R, QR is maximum 3 to 5 small squares. So that is the normal value of your PR interval. Anything more than that, for example, your PR interval is 8 small squares, it is a prolonged PR interval. Suppose your PR interval is just 2 small square or 1 small square, it is a short PR interval. So these two abnormalities can be there. Prolonged PR interval or a short PR interval can be there. We will see what it means. PR interval, if it is prolonged, that is more than 3 small squares, 5 small squares, then it means the AV node is diseased. There is a problem in the AV node which is giving excessive delay. It is giving more delay than what it is expected to give. So that is called, well, that is what we call it as a AV block. There is an excessive block at the AV node. The AV node is diseased, there is an excessive block. We call it as a AV block, or in other words, we can also call it as a hot block. Generally, we call the AV node as a hot block also. So that is the impression. So whenever you see a prolonged PR interval, then what we have to understand is the problem is there in the AV node, which is giving additional block or excessive block. Suppose if it is short, your PR interval is short, let us say just 1 small square or 2 small squares only, less than 3, then that means the impulse is not going through the AV node at all. If the impulse is going through the AV node, it has to have a delay. There may be some situations where there is an abnormal accessory pathway. Accessory pathway means abnormal additional pathway, which is bypassing the AV node, directly connecting the atrium to the ventricle. If the impulse is traveling through that accessory pathway, again, it is not going through the AV node, so it will not produce any AV node delay. There will be no PR interval, there will be no delay at all at the AV node. So there are only two delay possible abnormalities possible in the PR interval. If it is prolonged, you can say there is a AV node problem. There is a AV block. If it is short, you can say there is an abnormal pathway. So to this level from the ECG, looking at the PR interval alone, you can diagnose the health of the AV node. I'll give you adequate examples. Let us say this is once again the same ECG which I showed you earlier. It is a normal ECG. Concentrate for PR interval. Once again, concentrate on the lead to the PR interval. How do you measure? From the beginning of the P to the beginning of the R wave. Yes. Hardly about 3 small squares only. 3 or maximum 4. So it is a normal PR interval. Your normal PR interval should be this much only. Just 3 small squares. See, from here to here, it is 5 small squares. It is about 3 small squares. So that is the normal PR interval. So that means what do you understand? When you see a normal PR interval, you can definitely say there is no pathology in the AV node. AV node is healthy, doing its job perfectly, no problem. There is no AV block. 100% you can rule out a pathology right here. When you see a normal PR interval. I will show an example here. Let us see this ECG. Again, concentrate on lead 2. See the P wave followed by the QRS interval. So if you see this, this is the PR interval. If you measure this PR interval, how do you measure the PR interval? From the beginning of the P wave to the beginning of the QRS. How many small squares are there? 5 here, another 3 here. About 8 small squares are there. Normal upper limit is only 5 small squares. Here it is 8 small squares. So what do you understand? What we understand is there is a prolonged PR interval. So whenever there is a prolonged PR interval, what we have to immediately understand is there is a problem in the AV node. The AV node is not functioning normally. It is diseased. It is giving excessive delay, which is called the AV block or heart block. So this patient, immediately, by the look of it, prolonged PR interval, you can say straight away, you can make a diagnosis. You don't need a EP study or anything. Straight away, you can say there is a problem in the AV node, there is a heart block or AV block. So that is the interpretation here. Similarly, I will show another ECG, is the AV block. See here, see this ECG. P wave followed by the QRS. See how much distance is there between the P wave and the QRS. See the normal P wave here. See, that's all. This is how it should have. Whereas see this here. Such a wide gap between the P wave and the R wave. So that is a wide, prolonged PR interval, which will tell you straight away that there is a problem in the AV node. No, but that 100% you are correct. So you can definitely fix the pathology. That is the problem. Let us say, for example, take this ECG. The lead 2 doesn't show the P wave nice. Yeah, lead 2 is this. See the P wave followed by a QRST. P wave followed by a QRST. So obviously there is so much of distance between the P wave. It is almost 11 small squares here. So this is also a case of AV block or a heart block. Right? So immediately looking at the PR interval, you can diagnose, fix the disease at the AV node. Then I told you about an accessory pathway. What is accessory pathway? Normally, impulse from the SA node should come to the AV node, gets delayed here, then subsequently gets conducted to the ventricle. That is how normally it should happen. Some people congenitally may have an abnormal pathway which is directly connecting the atrium and the ventricle. Sometimes the impulse can travel in this path also. So when this impulse travels through this pathway, then again there is no AV node involved at all. It is not going through the AV node. So when there is no AV node, where is the question of AV nodal delay? So there is not going to be any delay at all. As soon as the impulse reaches the atrium, it gets conducted to the ventricle. So there is no protection to the ventricle node. That is why people with the accessory pathway get a lot of supraventricular tachycardia frequently. That is why. Because it is not going through the AV node anymore. So if you see, what will happen when it bypasses the AV node, there will be no PR interval at all. If only the impulse is traveling through the AV node, there will be PR interval. Now it is traveling through a normal pathway, there will be no PR interval at all, or the PR interval will be very short. So if there is a short pathway, it is an accessory pathway. Let us say, for example, let us see here, this is the P wave, immediately followed by the QRS, almost one small square. In fact, there is no PR segment at all. See here, P wave, at the end of the P wave, the QRS has already started. There is no PR segment at all, so there is no PR interval at all. So this we call it as a short PR interval. So whenever you see a short PR interval, you can immediately say, you don't need to do mapping or anything. Straight away you can say there is an accessory pathway, abnormal pathway, which the commonest accessory pathway we get is Wolff-Parkinson's White syndrome, WPW syndrome. So WPW syndrome, the classical hallmark is a short PR interval, right? So these are the two abnormalities as far as the PR interval is concerned. Prolonged PR interval, AV block. Short PR interval, accessory pathway. That's all. These are the two abnormal pathways. Why should you break your head to understand this? There is a clinical implication to see whether it is a prolonged PR or short PR. Because if it is a prolonged PR, you must avoid or reduce the beta blocker. You should not start a patient on beta blocker because beta blocker will further suppress the conduction. Already conduction is suppressed, delayed. You should not give a drug which will complicate the situation. So you must not give beta blocker, or if he is already on a beta blocker, you have to reduce the dosage. That is the clinical implication. Whereas, if it is a short PR interval, you should give beta blocker. Why? Because you have to prevent a tachycardia, supraventricular tachycardia in future. For that, you have to give as anti-arrhythmic drug, as a prophylaxis, you have to give a beta blocker. So that is the difference in clinical implication. If it is a prolonged PR interval, you should not give. If it is a short PR interval, you should give. So such a vast difference in the clinical implication. That is why you must carefully look at the PR interval in the ECG. And I hope that is you are clear about it. We will now move to the next wave. So the impulse SA node to the AV node is atrial depolarization. That is the P wave. From the P wave to the R wave is the PR interval, which represents the AV nodal delay. Now the AV node has done the job. The impulse is now coming to the ventricle. The ventricle, when the impulse reaches the ventricle, it produces a ventricular depolarization. That ventricular depolarization is represented in the ECG as the QRS complex. Actually, I should call it as a QRS complex and not QRS wave. But colloquially, for convenience sake, we call it as a QRS wave. Q is a separate wave, R is a separate wave, S is a separate wave. All three put together, we call it as a QRS complex actually. So this QRS complex represents ventricular depolarization. So what is the ideal lead for assessing QRS would be your V chest lead, that is V5 and V6 leads are the best leads to analyze the QRS wave. So how do you measure the QRS? Should be measured from the beginning of the Q wave to the end of the S wave. Many of us make the mistake of measuring up to here only. We think the QRS has ended here, whereas it is not here, it is up to here. That is one more small square here. So up to the end of the S wave, we have to measure. From the beginning to the end of the S wave is how do you measure? So this is a wave. So it has again two components like your P wave. This has two components. One is the height, another is the width. There are two components. So the abnormality can happen either in the height or in the width. So what is the normal value for height? What is the normal value for width? That's what we are going to see that. In the height aspect of it, we don't give much importance for the amplitude or the height of the QRS because the height of the QRS can be influenced by many factors like a thick chest wall or a emphysematous chest wall or obesity or a very thin chest wall, pericardial. So many conditions can affect the QRS height or the QRS amplitude. So we don't give much of importance for the height of the QRS. But anyhow, there should be upper limit. There should be a cutoff. We cannot accept every Q or QRS as a normal QRS. There is an upper cutoff point. That is less than 26 millimeters. Millimeters means small squares. 26 small squares. So the height of the QRS in V5, V6 should not exceed 26 millimeters. If it exceeds more than 26 millimeters, we call it as a tall QRS. Tall QRS. That you measure the QRS amplitude only in the chest leads. Chest leads means, I mean V1, V2, V3, V4, V5, and V6. We don't take into account the lead 1, lead 2, AV or AVL. They are called the limb leads. We don't count or measure the height of the QRS there at all. Because in the limb leads, the QRS height depends on the axis of the heart. So we don't give importance at all. The importance is given in chest leads. Again, the height maximum of 26. Anything less than, for example, 11 normal, 14 normal, 24 normal. We don't give much. 20 more than 26 is abnormal. So that is the height. But what importance we give is the duration. That is the width. Your QRS should maximum occupy only 2 small squares. The width of the QRS should not be more than 2 small squares. If it is more than 2 small squares, we call it as a wide QRS. I will tell you what is the clinical implication. What do you understand if it is a wide? What do you understand if it is a narrow or normal QRS? So this you have to clearly remember. The width should not be more than 2 small squares in other words, 0.08 seconds. So that is the maximum normal value of the QRS. See, this is how you measure from the beginning to the end of S wave. So this QRS, see, whenever See, what happens is why the QRS is so narrow, just two small square is when the impulse is traveling through this specialized conduction system. You know what is the specialized conduction system? Bus, his bundle, right bundle, left bundle, or anterior fascicle, posterior fascicle, Purkinje fascicle. That is called the specialized conduction system. If the impulse is traveling exactly along this path, this is how it has to happen. When if it travels along this specialized conduction path, then your QRS will be narrow. It won't be wide at all. It will be narrow. That is two small squares or less than two small squares. It won't be more than two small squares. But for some reason, there is a block. You must have heard of bundle branch blocks. You must have heard of a fascicular blocks. That means there is a problem in the conduction system. It gets fibrosed, not conducting the impulse. Whenever the impulse gets blocked, whenever the impulse has to travel through the non-specialized conduction system like the muscle, then the QRS will be wider. So with this knowledge, we can now say, if the QRS is narrow, what is that you can say? 100% there is no block. Definitely the impulse is traveling only through the specialized conduction system. You can swear on earth that there is no bundle branch block, there is no fascicular block, nothing, no problem at all. The entire conduction system is fine, normal, healthy. But if the QRS is wide, you can again swear on earth and say there is definitely some block in the conduction system. We will not tell you right now where is the locality, but just say there is a conduction abnormality, there is a conduction problem. So that is the clinical implication. If the QRS is narrow, the entire conduction system is intact. If the QRS is wide, somewhere in the path there is a block, there is an obstruction. That is the clinical implication what you have to understand. So there is narrow QRS, no distal conduction block. Wide QRS, there is some conduction block. Similarly, that is about the width. Suppose there is a tall QRS, then there is a ventricular enlargement. Just like the P wave. I told you when there is a atrial enlargement, it will be shown as the height, tall P wave. Similarly, if you have a very tall QRS wave, you must suspect a ventricular enlargement. One caveat I would always like to remind you is whenever you suspect a chamber enlargement, it should always be confirmed by echocardiogram. So repeatedly, you would have observed, I said only possible right atrial enlargement, possible left atrial enlargement, possible ventricular enlargement. We can only say possible. We can only guess. Most probably will be right. But 100% confirmation should always be done by the echocardiogram because ECG for chamber enlargement has only a high specificity, but it has a very low sensitivity. Meaning that even in the presence of a ventricular enlargement, the ECG can be normal. Whereas if you have a very tall QRS, almost you can be sure that there is a ventricular enlargement, right? So ruling out is not possible with ECG. That is why it is always to be confirmed by an echocardiogram. Let us take some examples. Once again, the same ECG I am showing because this is a perfect normal ECG. Let us, for now, we are concentrating on the QRS complex. QRS complex, the ideal lead is V5 and V6. Do not look at the chest leads at all. We don't care here. We look at the limb leads, chest leads. V5, V6 are the best leads. Now you see this. This is the height of the QRS. This is the width of the QRS. What is the height of the QRS here? 5, 10, and another 4, 14 small squares. That is 14 millimeters. That is well within the upper limit of 26 millimeters. So it is a normal QRS amplitude. So what do you understand by this? It is unlikely that this patient has a ventricular enlargement. Carefully worded. You cannot say 100%. It is unlikely that this patient has a ventricular enlargement. That is one thing you can say. Similarly, measure the width. That is just 1.5 small space only, very narrow. No, it's packed, sitting on each other. So it is just two small squares here. So what is that you understand from this ECG? Immediately you can say there is no conduction block. You can challenge in the court. There is no conduction block. So you can say two things. Unlikely to be have an enlargement and 100% there is no distal conduction block. This is the interpretation of the QRS waves. Let us say, for example, let us take this ECG. Here the graph is not well printed. It is, take this here. Let us take this here. Do you think it is a normal QRS wave? See the QRS here in lead one. This is the normal. See the QRS here. See what is the abnormality here. It's a very tall QRS. See if you can measure from here to here 5, 10, 15, 20, 25, 30, 35. Probably it is even more than that. So the amplitude or the height of the QRS is 30 millimeters or 35 millimeters. So it is a tall QRS. So moment you see a tall QRS, what do you understand? We understand that likely that this patient has a ventricular enlargement. So right or left, we will see later. It's not part of today. It is a different chapter by itself. So just understand there is a ventricular abnormality, ventricular enlargement. That decision, it is enough you make. So it's an abnormal QRS. So immediately you diagnose a ventricular enlargement, right? See this QRS. Do you think it is a normal QRS? See this QRS. See this QRS. Obviously, see this QRS, how narrow it is. See this QRS, how broad it is. V5, V6 are also broad. See the QRS wide. So there is no problem with the height. The problem is in the width. So it is a wide QRS. So whenever there is see a wide QRS, what do you understand? There is a problem in the distal conduction system. It could be a bundle branch, it could be a fascicular block. We will not go into it today. It is possible to localize, but that is not the scope of today's lecture. So it is, you can understand, swear 100% say, definitely the impulse is not traveling through this specialized conduction system. It is traveling through some non-specialized conduction system due to some block somewhere. It is traveling through muscle. You can say this. So there is a diagnosis. There is a conduction block. See this ECG. Now, obviously, moment you see that there is a white QRS, then immediately you must identify, you must know that the white QRS is happening because there is a block in the conduction system. That is why the impulse is traveling slow, and that is why the QRS gets widened. So it is a obstructed wave. So it is a distal conduction block, which is represented by a wide QRS. See here, even this is a wide QRS. Some people get fooled or cheated by this narrow complex. From here to many of us, our eyes look at it only. QRS means you will look at this only, look at this only. It looks so small, so narrow. It looks like a normal QRS, but actually it is a wide QRS. Why it is a wide QRS? You have to measure from the beginning of the Q wave to the end of the S wave. See, your S wave is here. It goes up to here. This is the end of the S wave. So from here to here, if you measure, it is actually 3 small squares or even more than that, even 3 to 4 small squares. So it is not a narrow QRS as it apparently looks. It is not normal. It is actually a wide QRS. This ECG I am bringing to your attention because just to bring it to your focus that you have to measure up to the end of the S wave and not here. You should measure up to here. So if you measure actually, it is a wide QRS. So when you say a wide QRS, you be 100% sure. No, nobody can question you. You can definitely say there is a conduction block, right? Wide QRS as just need not be this wide, not necessarily. Even this is a wide QRS. Anything more than 2 small squares is a wide QRS. Please understand. Sometimes you may have a low voltage. So we know what is the abnormality in the height, ventricular enlargement, abnormality in the width, the conduction abnormality. I have shown you enough of ECGs to identify this. Sometimes you will have very small dwarfed, very small QRS waves like this. That's called as the low voltage complexes. Typical clinical scenario is some pericardial effusion, mixed edema, hypothyroid state, obesity, or emphysema chest. All those things can produce a low voltage complexes. So the definition or the criteria to call it as a low voltage complex is QRS less than 5 millimeter in the limb leads. These are the limb leads. The height should be less than all the 6 leads. It should be less than 5 small squares or less than 10 small squares in the limb leads, chest leads, I'm sorry, in the chest leads. That is the criteria to diagnose a low voltage complex. Limb leads, it is 5. Chest leads, it is 10, less than 10 is the cutoff point for calling complex as a low voltage ECG complex. If you see a low voltage complexes, then immediately your mind should look your you should look for a thyroid disease. That's the commonest condition, or it could be a pericardial diseases, right? So these are the three abnormalities in the QRS complex. Then the fourth abnormality could be sometimes you may not see the R wave at all. You see only the Q wave followed by a ST segment and the T wave. You see only the Q wave followed by a ST segment and T wave. You don't see the R wave at all. If you don't see the R wave at all, then you must suspect an infarction. What is infarction? It is the death of the myocardial cell. It has become a scar. Your QRS will be produced if only there is a healthy myocardium to get depolarized. When there is no healthy myocardium at all, the impulse cannot depolarize a scar. Suppose there is an extensive anterior wall infarction, old infarction. That means the entire anterior wall is become non-viable. So obviously it cannot be stimulated by an electrical impulse. So that is the scar. So if you don't see a R wave at all, then you have to understand that there is probably no healthy myocardium under that. So probably there is a scar or a old myocardial infarction. So about the QRS, four possibilities: height, enlargement, width, block, conduction block, small, low voltage, or absent infarction. Four abnormalities as far as QRS. Any QRS abnormality will be within this one of the four, right? Then we will come to the most important segment, that is the ST segment. ST segment represents the end of depolarization and the beginning of the repolarization. So this is the ST segment. This is the ST segment. It is a segment. This is a segment, horizontal segment. So it has no amplitude. Actually, it has no duration also. Normal duration is also not there. It is a very important, crucial segment. All your myocardial infarctions has its impact on the ST segment only. There is no specific measurement at all, either in the height or in the width. But what is important is the shape and the configuration are very, very important. This is the picture which you have to memorize and keep it in your mind. The shape and configuration. What is the shape and configuration? Every word of it is here. There is an imperceptible smooth merger of the S wave and the T wave. See, this is the S wave. This is the T wave. There is a very smooth merger. You do not know where the S wave has ended. You do not know where the T wave is beginning. It is a smooth merger, just going ahead, just crossing the midline and merging with each other. There should be a smooth merger like this and a gentle concavity facing up. This is the small concavity which is facing up. And third, not hugging the baseline for more than 3 millimeters. That is, this is the baseline. It should not come like this. Stay horizontal for some time, then take off. That should not happen, at least for 3 to 4 millimeters. So these are the criteria. It should gently, concavity should be there. There should be a imperceptible merger of the two waves, and it should not become horizontal, then take off. All three are not there. So this is the normal ST segment. Any alteration from the shape, anything, the ST segment should be exactly like this, 100% like this. Any alteration or any mild elevation of this ST segment or any mild depression of the ST segment represents an acute coronary syndrome, meaning that it is an emergency. So if somebody patient comes with a chest pain, you look at the ECG, do the ECG, look at the ECG, concentrate on the ST segment. If the ST segment is not exactly like a normal ECG, then call it as an abnormal ECG, call it as an emergency, admit the patient, and you have to observe the patient. That is an emergency, it is an acute coronary syndrome. See here, this is a normal ECG, normal ST segment. The ST segment can be a very abnormal like this, there is a horizontality. This is what I told you. It becomes a horizontal. It becomes a depressed. This is an ST depression. This is a sagging ST depression. See, compare this and see here. And this is the horizontality. This is ST elevation. See that it looks so normal. This is the commonly missed pattern. It looks so normal compared to this and this. It looks fairly normal. But what is the abnormality? This concavity is lost. This is a very important finding. The loss of concavity, which we call it as ironing out or straightening of the ST segment, as if somebody has put an iron box and ironed the ST segment, it has become a flat, crease free, or concavity gets lost. So when there is a loss of concavity is the earliest evidence of an acute coronary syndrome. 2 hours later, the ECG will become an ST elevation like this. This is how it begins. So these, if you see any of these abnormalities, you should call it as an acute coronary syndrome. You should call it as an emergency. You must admit the patient and observe the patient. This is the most important. So there is no normal value. There is no normal height. There is no normal width. It is the shape. Smooth merger, concavity up, not staying the baseline. 3 characters for ST segment, right? Just to give you some examples, obviously, this is the baseline, and this is the ST segment. Look at this ST segment, grossly below the baseline. We call it as a ST depression. It is an ST depression, obvious ST depression. See here, this is the baseline. The ST is elevated. This is the ST segment. It has gone up. So that is ST elevation. ST elevation, acute ST depression, both are acute coronary syndrome, both are infarctions, heart attacks. See here, classical. See this ST elevation. This is the baseline. ECG, ST has gone up. It is lifted up. See this, it is lifted up. See here, it is lifted up. So it is ST elevation, myocardial infarction. There is equally, parallelly, you also see some ST depressions here. This is the classical ST depression. Why this ST depression and all is beyond the scope of this talk. See here, this is the earliest, this is what I told you. This is the one which is commonly missed. See, a person who has not read ECG will call this ECG as a normal ECG and send the patient home. He will go home and die at home. Because this is the earliest evidence of acute coronary syndrome. You're ironing out, straightening of the ST segment. See, normal, anything which is different from a normal shape of the ST segment is abnormal and dangerous. That's what you have to understand, right? See here, horizontality of the ST segment. See, this is how it will begin. See, just it is not supposed to be like this. It should smoothly merge. S wave and the T wave should just like that connect to each other. Whereas see here, S wave is ending here. There is a horizontal segment. Then the T wave takes up. This is permitted up to 4 small squares. If it is more than 4 small squares or 3 small squares, then that means it is an abnormal horizontality, which is the beginning of the next lesion, that is the ST depression here. So this ST depression begins like this only. So if you can identify a problem at this point of view, you can prevent this point of view. Here there is already some damage has happened. Whereas here the damage has not yet happened. So it is up to us to identify the simple. It looks so normal. The abnormality is only the horizontality of the ST segment. That's where we have to pick up. That is about the ST segment. I'm sure I'm taking some time. I'll take another 5 minutes, 5 to 8 minutes and close. Then the last wave is the T wave. You have completed the ST segment. Then the last wave is the T wave. T wave represents, ventricular repolarization. How do you measure the T wave? From the beginning to the end of the T wave like this. So it is a wave. It has 2 components. One is the height, another is the width. We don't give any importance for the height or width in the normal scenario because the height depends upon the QRS, height of the QRS. If the QRS is very tall, your T wave also will be tall. If the QRS is small, your T wave also will be small. If the depolarization is high, your repolarization is highly charged, like that. So amplitude of the T wave correlates with the amplitude of the QRS. But anyhow, there should be a cutoff, that is maximum 40% of the preceding R wave. Your T wave height should not be more than 40% of the R wave. For example, if the R wave height is about 10 millimeters, your T wave should not be more than 4 millimeters. 4 millimeters in the sense 4 small squares. So like that, it should not be more than 40% is a tall T wave. And it should not be less than 20% of the previous. So normal height of the T wave should be 20 to 40% of the preceding R wave. That is the normal value. And again, width also depends on the width of the depolarization. But what is important about the T wave is the direction of the T wave. The direction of the T wave should be the same as the QRS direction, dominant QRS direction. If the QRS is predominantly positive, your T wave also should be positive. Positive means upright. If the QRS is predominantly negative, your T wave also should be predominantly negative, that is downward. If you have a tall upright QRS and an inverted T wave, that is abnormal. If you have a deep negative QRS and a positive T wave, that is abnormal. So what is important about the T wave is not the height in many situations. It is the direction of the T wave, whether it goes with the QRS or it is going opposite to the direction of the QRS. That is the significance of the T wave. This is how you measure. So if the QRS is upright and the T wave is negative, it is abnormal. If the QRS is negative and the T wave is upright, again it is abnormal. If there is a QRS is small, but the T wave is very big, more than 40%, then it is abnormal. Similarly, if there is a very big QRS, but very small, less than 20% T wave, it is abnormal. So these are the four abnormalities a T wave can have, right? I will show some ECGs also. Look at this ECG. Look at this T wave. Concentrate only on the T wave. We have so many abnormalities here, but concentrate only on the T wave, for example. See, this is the T wave. Do you think this is a normal T wave or abnormal T wave? Obviously, it is an abnormal T wave. Why it is abnormal? Because your QRS is upright, whereas your T wave is out, down below. This is up, this is down. So this is an abnormal T wave. See again, your QRS is predominantly negative, whereas your T wave is opposite, upright. So that is the direction of the T wave, which tells you that there is an abnormal T wave. I will tell you subsequently about the abnormal T wave. So only caveat here is, just because a person has an abnormal direction of the abnormal direction of the T wave, don't brand him as a case of coronary artery disease. This is another very common mistake every general practitioner makes. Any small T wave tells the patient that you have an abnormal T wave, go to a cardiologist, have your check. For the next few days, he will not sleep in the night at all. And so far he wouldn't have had a coronary heart disease. Now he would develop a coronary heart disease because of the anxiety. That's the problem. So please understand, all T wave abnormalities are not pathological. There are thousands of non-cardiac conditions which will produce the T wave abnormality, or which will change the T wave configuration. Coronary artery disease is one of the 1,000 causes. So every T wave inversion or every T wave abnormality is not coronary artery disease. There are 1,000 reasons. The coronary artery disease is only one of the reasons of the 1,000 causes. That's what you have to clearly keep it in mind. Then comes the QT interval. I'll just rush it fast. It is the beginning of the depolarization. I'll just skip it from the Q wave to the T wave. I'll skip all that. Normal QT is corrected to the heart rate, that is 0.45 seconds. Or let us not bother much to do this calculation and all. Every computerized ECG machine will give this calculation, QT and QTC. The normal value is 4.45 or 450 milliseconds. That means if it is more than 450, we call it as a prolonged QT. If it is less than 450, it is short QT, right? So what is the long QT? Commonest cause is a congenital long QT. Many drugs, most of the time long QT is caused by the drugs. Typically the HCQ, what we used for during corona, typically produces a long QT. Bradycardia, some of the poisons like that. Short QT is again digoxin, and then again calcium metabolism produces its impact on the QT. The significance of QT interval is, always see the QT interval when the patient, especially children, comes with a syncope. You know, you would have had patients where the children brought by the parents that the child fainted in the prayer hall. We think it is a vasovagal episode. Actually, if only you do the ECG, you will identify a prolonged QT interval, which is a dangerous abnormality. What is the danger? A dangerous complication is a sudden death. If these people with a prolonged QT or high risk patients for a severe life-threatening tachycardia and sudden cardiac death. So whenever, especially children, come with a syncope, please check the ECG. And when you do the ECG, concentrate on the QT prolongation. That's very important. If there is a QT prolongation, he has to be referred to a cardiologist, worked up further what is the cause for the QT prolongation, and take preventive measures. Just to give you an example, this is the normal QT. See the QT here, prolonged QT. See the QT here, just visual comparison. This is a short QT. This is a normal QT. This is a prolonged QT. So by just looking at the ECG at a glance, this is a nice title which your secretary has given, glance, looking at the glance. Looking at the ECG at a glance, you can diagnose this is a hypocalcemia, this is a hypercalcemia. You need not even check the electrolytes. Looking at the ECG at a glance, you can diagnose it is hypercalcemia, this is a hypocalcemia, and say here that the calcium is normal. So that is the advantage of the ECG. The last wave is the U wave. Your U wave is a small wave which comes after the T wave. Normally, your U wave should be smaller than the T wave, whereas if the T wave is small and the U wave is very big, you should suspect hypokalemia. Just keep it in mind. If you see a prominent U wave, it is a hypokalemia. See here, normally after the T wave, you see a small positive deflection, which is the U wave, and that is normal. Whereas if you see a U wave like this, for example, this is the PQRS T wave, followed by another big wave that is called the U wave, which is even bigger than the T wave. Then it is a prominent U wave. Then the suspicion should be a hypokalemia. Immediately suspect, check the potassium. Many times you will be right in the diagnosis, hypokalemia. Sometimes your U wave can be inverted like this. Then if you see an inverted U wave like this, that is a subtle sign of a coronary artery disease. Whereas your T wave inversion, no other investigation will show this. This could be a very useful finding in identifying a coronary artery disease. Inverted U wave, positive T wave, inverted U wave is a sign of coronary artery disease, right? So what are the abnormalities? Small t and a large u suspect hypokalemia. Upright t and inverted u suggest coronary artery disease. Just keep it in mind. So with this, let me complete my lecture. I am not sure whether it was beneficial to you in any way. Let me stop sharing this. I am open for questions. If there are anything to be answered, I am open to that.
Thank you, sir. It was excellent lecture, sir. Actually, you made it easy for us. So it's a fantastic lecture, sir. So, doctors, we can have a question and answer session. If anybody has wants to ask question, you can unmute yourself and ask. Or in the chat box also, you can write the question.
We have certain things there in the chat box. I think many of you, I swear on that you are the best teacher of the ECG lecture. Expecting some more classes. Thanks a lot for the comments, sir, Dr. Maidil, madam. Can you please send the recording of this program?
Yes, sir. I will.
You have the recording?
Yes, sir. We have recording, sir.
Very nice, very nice, very nice. You can send it, madam. I have no objection. Excellent. Can I have the notes on the lecture? I think madam is going to send you the video itself, so not an issue. Thank you so much. There are no questions in the chat box. Anybody wish to ask something? No, I'm sure you can all confidently diagnose right atrial enlargement, left atrial enlargement, ventricular enlargement, conduction blocks, AV node abnormality, and coronary artery disease, and ST segment abnormality, and U wave abnormality, hypokalemia. So at the end of the lecture, you are now confident of diagnosing certain things, and also you can confidently say there is no disease also if you see a normal ECG, right?
It was very simple, sir. Actually, you made it very simple. Most of the time, we don't know it is normal or abnormal. So, which lead we to read the P wave or QRS, which lead we have to see. That's not all. Also, I am not aware of actually. So, we clarified everything. Thank you, sir.
Excuse me, sir.
Tell me, doctor.
ST segment, in which lead we have to see, sir? ST segment?
No, in all the leads, all the 12 leads you have to see, because each lead looks at the heart from a different angle. For example, if the ST segment abnormality is there in the lead 2, lead 3 and AVF, you will not only diagnose an infarction, you will also say it is in the inferior valve. The problem is happening in localization.
Okay,
Locally,
sir.
where exactly it is happening is given by the which leads it is present. You have to see the ST segment in all the leads. Any lead abnormality is an abnormality in all the 12 leads.
Okay, sir. Thank you, sir.
My contact
Sir,
number is, you can
sir, I
note down.
have one more. I have a question.
Let me
Sir,
answer the previous question. 1 minute. Somebody wanted my contact number. 94433 5427. I will type it in the chat box itself.
Hello, sir. Hello, sir.
Yes, sir. Yes, sir.
I am Dr. Ramsamy speaking, sir. Somebody diagnosed a non-specific ST changes. What
That's
is your opinion?
Yes, sir. So that has to be clinically correlated, sir. So the ECG has to be always be clinically correlated, sir. Because for the same ECG, the diagnosis or the interpretation is different in different clinical situations. For example, a 10-year-old boy, you take an ECG, you have T-wave inversion. For the same T-wave inversion, if it is a 50-year-old person coming with a chest pain, I will make a diagnosis of anemia. For the same for a 5-year-old boy, I will call it as a juvenile change. It is not a pathology. For the same TV emission, all three ECGs look alike. For the same ECG, suppose a young, recently married woman having a lot of stress at home, coming and crying, weeping in the mid of night, you do an ECG and ECG shows a TB inversion. I will call it as a non-specific because it doesn't fit in. Patient has no risk factors and thing. And again, unless I take you to a next chapter on coronary artery disease, ECG on coronary artery disease, what is the typical ECG finding in the coronary artery disease? What is the typical ST depression coronary artery disease? Whichever is not typical of it, we call it as a non-specific or atypical, sir.
Thank you, sir.
Have I answered you, sir?
Thank you.
So it has to be clinically correlated, sir.
Okay, sir.
Sir, good evening, sir. Shall we have a continuation of this program, sir? Next continuation.
It will be my pleasure if you want it. It will be, I
So,
can take an
what
entire
about
course on ECG, everything on the ECG, no problem.
ST elevation in AVR?
You are asking for a 1 hour lecture, ma'am. ST elevation, it is a very commonly missed thing. That depends upon the axis, number one, whether the impulse is traveling towards the right axis or the left axis, abnormal axis. Then ST elevation AVR gives a lot of localization, proximal. Suppose there is a patient with anterior wall infarction with the AVR ST elevation, that tells you that ST is, has got anterior wall infarction. Not only that, it also localizes the block to a proximal LAD, proximal left anterior descending artery. So that has a lot of localizing values. Then again, ventricular premature beats will have a ST elevation. There are about 10 to 15 causes. We can have 1 hour lecture on ST elevation in AVR alone.
Okay, sir. Okay, sir. Thank you, sir. Thank
There
you, sir.
are a lot of reasons for that.
Maybe we can have an advanced session also, sir.
Better.
That's what I asked you earlier, madam. What is that you want me from? Is it an advanced ECG or a basic ECG you wanted? Is it basic?
But this time is basic is good, sir. Maybe next session we can have the advanced one.
Sure. Whatever you want on ECG.
That good talks actually. You are great, sir, about ECG.
Whatever you want. Another good topic would be an abnormal beat. For example, you see the ECG, suddenly you find an abnormal beat. What is that beat? What to do with the beat? That confusion will also be there. That's a good topic for beginners. I can talk to you anything on ECG if you are interested in the ECG learning. Generally, people are not interested in ECG because the moment they start reading it, they get bored, confused, and ultimately they lose interest in ECG. That is why initially itself I said one of the scope of the talk is to create an interest in ECG in you. If you develop an interest, you are welcome. And again, I welcome you, or option is open for you to join our ECG club also. Just to tell you about 1 minute and about our ECG club. We have a club in Trichy. For chairman is Dr. Chenniyappan, ECG club and ECG and Echo Club of Tiruchirappalli. We meet every Thursday at 9:30 in the night.
Okay, sir.
Previously, we were doing only physical meetings. Now we are switching over inevitably to Zoom meeting also. So we have members all over India actually now. And we have a discussion on an advanced ECG plus a topic on cardiology. Of course, it's a paid membership, 5,000 rupees per year. And if somebody is interested in ECG and cardiology, that will be a very good platform to learn more. I am the secretary for that. If you are interested, you can contact me anytime. I can guide you in joining the ECG club.
Thanks for that information, sir.
Thank you.
Anybody has any questions?
Any further questions? Generally, ECG talks won't attract any questions, madam. That's what I have seen.
But you made it very clear, sir. Maybe that is the reason also.
That's right. That's right. I want to join the WhatsApp group for ECG. Please, yeah, you note down my number, doctor. You just send me a message. I'll send you the details. You can join as a member anytime. No issues. Dr. Sasikala has asked for it. Thanks for the nice compliments, madam. Many of you have said it is a nice presentation. I'm surprised at it. Thank you so much.
With this, we
Thank
can,
you, sir.
Thank you.
Dr. Veena, ma'am, can we
Can
close?
we close this session?
You can wind up.
Sir,
Thanks a lot for a
it's
wonderful opportunity. I enjoy talking to you. Thanks a lot.
it's really a wonderful lecture, sir.
Thanks.
Useful to all.
Thank you once again, sir.
Thank you, sir.
Thank you.
So much for
Thank you.
answering. Thank you all doctors who participated today's seminar webinar. So thanks once again for everyone who attended the meeting. We'll meet you next monthly CEV program. Meanwhile, thank you so much. We'll
Thank
be
you.
closing the session. Yes, sir. Thank you, sir. Thank you so much.
Bye. 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 Good night.